I think the whole point of this, Patty, that needs to be communicated, the whole point being it is recognized in our system that we need to move from volume to value-based care. We need to. Now, there are obviously people that are resistant because they're making lots of money off of it, and people just don't like to change. When is our Medicare trust fund going to become insolvent? 2026. And so it is important to the taxpayer, to the people of our country, that we are on this journey.
Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision and the culture of healthcare systems. Welcome, everybody, to the License to Lead podcast. My guest today is Dr. Roger Fowler, the Vice President and Chief Medical Director of Quality, Performance, and Innovation at CHRISTUS Health, which is a healthcare system based out of Irving, Texas, with hospitals, clinics, physicians, and staff in 5 states and in Latin America. And he heads up the population health program as the medical director for CHRISTUS. Dr. Fowler is a family medicine physician, and he's passionate about figuring out how to provide the highest quality of care to everyone. He's convinced that we have to get there through measurement, benchmarking, and innovation. And he's particularly concerned with the lack of adequate funding and focus on primary care. And Dr. Fowler has been a wonderful gift to this podcast by giving me feedback and pushback about some of the topics and perspectives that have cropped up. And that has been just invaluable for me. So I roped him into coming onto the show to help me understand a few things better. So welcome to the show, Roger. I'm so glad to have you here.
Patty, it's such an honor to have you ask me to come on. I appreciate this opportunity. I love your podcasts. I listen to all of them and just continue to be stimulated in thought and actions by what your content has been. So thank you very much.
Wow. I really appreciate hearing that from you. Could you give us an idea of what your current role is, what you're doing and focusing on?
Sure. Thank you. I have the privilege of being the Chief Medical Officer for our Medicare Accountable Care Organization, where we have about 60,000 beneficiaries that we care for in our ACO across 4 states. I'm the Chief Medical Officer of our clinically integrated network, which is, think of it like the ACO with our commercial products like value-based contracts with Blue Cross Blue Shield, Humana, and others. And then as of 2 years ago, I'm now working within the CHRISTUS Health Plan. We have a TRICARE product where we sell it in primarily Houston and Southeast Texas. And then we have a Medicare Advantage product that is in Santa Fe, New Mexico, and Northeast Texas. And then we have a health exchange, also known as Affordable Care Act, or a marketplace plan that we sell in Texas and in Louisiana. And so I get to lead all of the clinical services within the health plan: medical management, utilization management, quality, pharmacy, and patient safety. And so, I have a pretty broad reach of influence within our organization, with the focus really being on quality performance, figuring out ways to do that, and think about things in light of that triple aim and how I can help all of my partners, and especially primary care, where most of that pressure is, to help them do this in the easiest way and to compensate them appropriately for doing this new work in healthcare that's not compensated in the fee-for-service system.
What is the new work? What does that entail?
That's a great question. I learned that through whenever I began my role in administrative medicine by getting our primary care clinicians within the Trinity Clinic a patient-centered medical home recognized by the NCQA. I really didn't realize all of the value and importance of quality performance, segmenting our populations, understanding all of our diabetic patients and their needs and what the evidence-based care for that population is, and how do we do that in an efficient way so that the clinician doesn't have to spend all of their time just doing this work. And so it's building teams that help us to accomplish that. But there's still extra work. You've got to take the time to ensure that every diabetic has the opportunity to have their eye exam done every 1 to 2 years, depending on the circumstance, that they have the opportunity to have their A1Cs performed on a routine basis, depending on what the control level is. And so those are the things that are extra above and beyond taking care of what that patient came in to see you for when they're in front of you right now, because that may be the only opportunity you have to contact them. And these things need to be done to try to optimize their healthcare. And it's extra work. And so it is that transition from volume to value-based care.
Yeah. I wonder if you could break that down for me a little bit, the volume versus value-based care.
So the healthcare system that we have in America right now started after World War II as a result of all of the converging factors in healthcare and post-World War II and how we were going to provide healthcare into our country. And so as a result, the employer-based healthcare system was born. It was primarily thought about that time that healthcare was to occur in hospitals. And so we were going to build hospitals within 15 to 30 miles of all of our citizens. We were going to finance that with the federal government. And as a result, our fee-for-service system was born out of employer-based health plans. Early in my life, health insurance was actually known as hospitalization insurance. There was no such thing as health insurance. And over time, it has evolved because when I first set up practice, primarily what was paid for was hospitalizations. I had to admit a patient to the hospital to get a physical exam paid for. I could admit them overnight and do the things that, quote, needed to be done. And in the 70s, 80s, there was not good evidence for what really was best. But, we were paid to put people in the hospital to do an EKG or do lab on them and to get it paid for so that the patient didn't have to pay out of pocket to get needed services.
So the crazy making incentives started there, perverse incentives to do more, and anything that was going to be adequately reimbursed was something that was done in the hospital. Otherwise, were the patients paying out of pocket?
Yes.
Okay.
I was delivering babies, and ultrasound was a very new technology. And so the only way that I could get a sonogram on a mother was to admit the patient to the hospital to get the sonogram done. Just another example of how our system was set up perversely and has continued in this fee-for-service volume world. The AMA created the CPT code system and the ICD system. They own that. It's based on doing procedures. And so that's that volume world. We're paid the more we do, not because what we do provides value to the patient. And so as we have seen that we're the most expensive, lowest quality developed country in the world, there is the realization that somehow we need to change that paradigm, change the incentives so that clinicians can do the right thing and get paid for it and not have to just continue to do things. And that's why I think we need to be paid appropriately for doing things, but for producing outcomes and not just for doing the thing.
That's so intriguing how entrenched the perversity is. And when you talk about employer-based healthcare or employer-based insurance, can you talk more about what that looked like? How did that spring up exactly?
Once World War II was over, we had more than 2 million men coming back into the workforce because primarily military was men then. There were a few women. And so as the men came back from World War II, there were officers and there were enlisted men. And so companies were trying to figure out, how do we attract the kind of talent we want to get back into our organizations to run our businesses well? Well, at the same time, there were price and wage controls, freezes. You couldn't offer more wages because of the inflation that occurred as a result of World War II. And so as a result, again, the federal government tried to help this whole process. What we can now offer is we can offer a new benefit known as hospitalization insurance, and it's a tax deduction for the business. So the business is incentivized to do it. The employee, the associate, has this extra benefit that this company is willing to provide to get this person. And then it'll pay for hospital procedures, nothing else, but it'll pay for you to go into the hospital and have procedures done. Having an appendectomy, or it was much less sophisticated amount of activities that occurred then, but it was still paying for stuff to be done within the hospital. So it was hospitalization insurance.
Was the government involved in reimbursement at that point?
It was not. Medicare didn't exist at the time. Medicaid did not exist at the time. Medicaid came along in 1968. President Johnson was the one that introduced Medicaid. Medicare came along earlier in the 60s. So the federal government was not involved in, financing insurance at that time.
Okay. That is really interesting. I derailed you a little bit. We were talking about value-based care. And if I understand how you've explained it, the volume-based care really sprung out of this early focus on everything that can be done in a hospital, gets reimbursed. You do more, you get more money back. And that's how we usually talk about fee for service. And in some metropolitan areas, the more specialists there are, the more procedures that are done and costs are higher, which is backwards from what you would think of with supply and demand. So that's the volume-based care versus value-based care, which must rely on being able to monitor and assess and describe some kind of value that's being provided. Am I in the right ballpark with that?
You're exactly there. Value-based contracts sprang out of the effort and the intent to improve quality, improve member or patient experience, and to bring cost efficiency, to bring that value. And so value-based contracts are contracts payers offer to clinicians or clinician groups on top of, as a supplement to a fee-for-service contract. And so you're rewarded for performing quality. And that's where HEDIS measures come in, or ACO measures come in. If you achieve a certain amount, then you receive some sort of reward for that financially.
Are you talking about the government with Medicare and Medicaid, or employer-based health plans, or insurance companies? Who are you referring to?
All of those.
Okay. Are the criteria then that all these disparate payers set up, are the criteria legit, or are they bogus and serving somebody, kind of follow the money? The quality metrics are illogical, or just not really assessing true evidence-based quality. There's a question in there somewhere, Roger. I bet you heard it.
I did.
Okay.
I've answered that question a lot. That's how I started this, was learning to answer that question right there.
Okay.
So all of the commercial payers like Medicare Advantage, the employer-based payers, Blue Cross, Aetna, United, they rely on NCQA, National Committee for Quality Assurance, HEDIS measures, Healthcare Effectiveness and Data Information Set, the HEDIS measures. And those measures now are pretty well set based on evidence-based medicine. And you can go to the National Quality Forum. They pretty much have a library of about as many quality measures as you can think of. And you can find the steward of that quality measure that you're looking at. And you can kind of see what they've based that quality measure on. And most of these that we are performing to now are all evidence-based performance measures. The CMS, Center for Medicare Medicaid Services, for our Medicare ACO, has what we call ACO metrics. And again, those are evidence-based metrics. We're at a point now where pretty much every plan that I work with uses either HEDIS or ACO measures based in evidence-based care. Medicaid, to me, is the outlier as the states get involved and they want to provide their interpretations. They sometimes get, kind of outside the boundaries.
I read something that you had written referring to NCQA as related to insurance companies. And I thought, what? I thought that NCQA was related to, I don't know, Institute of Medicine or something like that. Can you sort that out for me a little bit?
As insurance companies were looking for a way to rank physicians or to value physicians, they were looking for measures in order to be able to do that.
Why did they need to rank physicians?
Because they wanted the ones that were the highest performing, that would have the least cost. They were focused on cost.
And the they that we're talking about is?
Insurance companies.
Okay, gotcha.
You remember back in the 90s, maybe you were working for Kaiser then, so it wasn't as impactful.
Yep.
I was in Texas, and I was working in a strictly fee-for-service world, and managed care was brand new. President Clinton was in office. We were struggling with, well, what is managed care? And in essence, the insurance companies were just limiting procedures based on the cost of procedures. Every single MRI had to be authorized. You had to have a peer-to-peer explanation for what you were doing every single time. And the effort was just to avoid doing that because there were no evidence-based guides that they used or that I had any access to say when I should be using it and when I should be not using it.
So it was really a cost-cutting measure to just make it hard to get the more expensive procedures.
Yep. And we as clinicians, we never took on the task of saying, you know what? We should be determining what quality really is. We should be determining what we should be measured by. We just pushed back and said no. And so insurance companies used the only thing that they had to try to develop quality measures, and that was claims. They espoused that they had all the information needed to judge the quality of a physician and what the quality of physician practice should be based on claims that were submitted, primarily based on cost of care.
So the physicians who maybe even gave up couldn't even deal with trying to justify and make all the phone calls and all that. They did fewer expensive procedures and fewer claims were filed. And then they were deemed rock star physicians by the insurance companies and were rated more highly.
Yep.
Wow.
That's who we want to contract with. So that was a pretty big failure.
Yeah.
Government got sued. The insurance companies got sued because they were denying important, necessary procedures.
And what was the government's role in that?
I don't know if you remember Hillary Care. We were trying to really enforce HMOs and managed care, and we were going to make primary care doctors gatekeepers without any kind of evidence, without any guidelines of what to go by. I just had to avoid expensive activities.
And it just puts you at odds with what's best for the patient. You have to be lucky not to be in a vice between doing the right thing for the patient and staying in good stead with the insurance company or the government.
Exactly. And so early on, I was a skeptic. I really was a naysayer. I didn't buy into this. And so that was, really before or just early around the time the Trinity Clinic was born. And I joined the Trinity Clinic in 96. We were just kind of dabbling in that sort of stuff. We didn't have an EHR at the time.
So no electronic health record.
No electronic health records. It made it exceedingly difficult then to know what your quality was because you had no comparison. There were no benchmarks. There was no data.
We'll come back and talk about the EHR. And I think for the listeners, this is Trinity Clinic based out of Tyler, Texas, which merged with CHRISTUS Health.
Yes, the Trinity Mother Frances system merged with CHRISTUS Health in 2016.
I know I keep derailing you into weird details, but
Patty, I think it's great. It's important you understand where we've come from. If we focus on what is best for the patient and then talk about payer, EHR, quality, talk about what is quality of life, what does the patient really want? Those are things that if we bring those together, then we can create a way to optimize the healthcare for people of America. But we've got to have the right incentives to really do that. That's, I think, what is important to understand about the way I think about EHRs, about payers, about direct primary care. I love direct primary care. If we could have every primary care clinician have a panel of 600 to 800 people and them to be compensated in the way that they can spend the time, the cost of healthcare in America would plummet and the quality would soar. We would not be having people going into the ED and going into urgent care nearly as much. They'd be going in for emergencies. EMTALA says you can walk in and out of an emergency room and never have to pay a dime.
You mentioned EMTALA, and people can go in and not pay a dime. And can you reconcile that with the horrendous costs of emergency rooms where they're just sticking it to people?
Of course. Back in the 80s, federal government got involved, recognizing that there were some hospitals that were redirecting ambulances. Somebody would come in with something really, truly emergent, a heart attack, a broken bone, an auto accident, and they weren't insured. And the hospital emergency room would say, no, we can't take care of you. Go down there to the county hospital. And so the federal government got involved. And so now we can't ask for any copays or any insurance or anything in the emergency room before you have seen a patient and completely assess them. And so, that's why people can do that without paying anything. An emergency room is staffed with some of the most, these folks are highly trained to be ready for some of the most critical activities. And at the moment, they've got to be able to assess very sick people, make the right decisions, and take the right actions. And yet you're having them take care of a kid with a snotty nose. You've got all these expensive resources spent doing something that, they don't need to be doing. And then, of course, the freestandings in Texas take advantage of this because they're not attached to the hospital, but they get paid hospital rates and they let people leave without paying anything. And they're out of network for everybody, but they've jacked their prices up enough to where they don't care.
Marty Macri wrote that book. I think it's The Price of Care, and details some of the criminal behavior that goes on, that they have helicopter services that are on the same ground with the emergency services and chopper people someplace when they don't need it. And then these poor people are charged for that. And I think everybody knows the statistic that the number one cause of personal bankruptcy is healthcare. And according to what Macri was saying, the physicians, they don't know that down in the billing department, that they've got all sorts of ways of billing the patients and then even taking them to court, jacking up the prices, and then suing them for not paying totally inappropriate prices for different services, and really do great harm.
I agree with you 100%. As I was younger and I was really a champion for a market-driven economy, but typically in that kind of economy, the consumer and the producer, they're kind of on level playing fields, that what you're buying, right? And what you're paying. In healthcare, it's not that way. And to your point, when you have more and more specialists in an area, you would think the price would go down, but in essence, it doesn't. It goes up. So market economy does not work in healthcare. It's just the opposite. We have this perverse payment system that's driving procedures. And I don't know the number now, but I know 6 or 8 years ago, it was documented that 40% of the stents that were placed in hearts were not indicated. People lived just as long once they were identified as having, a 70 or 80% blockage, as if you stented it open. They'd live as long if you had them on statin and on aspirin and blood pressure control. And yet cardiologists were incentivized, and the health systems incentivized to put those stents in.
Yeah. Now we are really, truly pointing the finger at the physicians who are making that decision, and they might be under some duress. We do know you do get what you incent.
I have many examples.
Can you give me one example?
So, and this is a physician-owned practice of cardiologists. And every time I would send a patient to this particular cardiologist in this group, if they found any vascular disease in their heart, they scanned their neck and they scanned their lower extremities. And if they saw a blockage in the lower extremities, even if the patient was asymptomatic, they would stent it.
Yep.
That's not evidence-based care at all. I showed them the studies that if they were asymptomatic and never had any issues, they should never be scanned asymptomatically. You are creating more risk and harm than you're doing good to that population. We're doing this to ourselves, but I can understand that it's the perverse financial incentive world that we live in. And whether the physician owns it and they are getting greedy, or whether it is the hospital systems, it is what's driving this issue. And so value-based contracts are an effort to counter that. And Medicare got into it because they recognized that with Medicare Advantage, they were getting higher quality care because there was management of that population. And they were using HEDIS measures to try and improve the quality of the outcomes. And so that's why the ACA came along and empowered accountable care organizations. And as a matter of fact, if you look at last year, our ACO was our Medicare ACO, one of 540 across the country. We saved Medicare together over $2 billion for the Medicare Trust Fund. And we continue to raise the quality of care for our populations.
The best of both worlds, then.
Yes.
Yeah.
And so that's what value-based contracts are intended to do. You put them on top of or in addition to that fee-for-service contract, and then you incentivize the clinicians to do the right thing of high-quality performance and patient-centric performance and paying attention to readmission rates and trying to avoid that and trying to avoid unnecessary admissions.
Roger, can you explain Medicare Advantage and ACOs?
You bet. So there are two separate things.
Yep.
Medicare Advantage was an experiment by Medicare back in the late 90s, another effort to try and reduce the cost of care for Medicare. Again, that was the time when the cost of healthcare, the cost of Medicare was increasing at about 9% a year. And the cost of standard of living was increasing about 3 to 4% a year. So it was just skyrocketing. And so they're trying ways to try and get a hold of cost of care. So Part C, Medicare, was legislated, which is Medicare Advantage. Medicare Advantage is a commercial insurance company. When you were in Colorado, Permanente health plan, you had a big Medicare Advantage population. And so as a commercial contract, as a commercial insurance company, you contracted with Medicare, with CMS, to take care of Medicare beneficiaries under your health plan. You were paid a premium for every single patient that you took care of under your health plan. And so you were given the latitude to manage that patient just like a commercial payer patient. You know, you could have a narrow network of clinicians. You could have a narrow network of facilities that they could go to that would be in network so that you had a relationship with those physicians and a relationship with those hospitals so that you could ensure that you were measuring quality and that you could, you know, try to incentivize clinicians to do the higher quality work. And so that was the essence of what Medicare Advantage, born in the late 90s, was intending to try to do to save Medicare costs. And it offloaded the risk. Once Medicare paid you that premium, then you as the insurance company were at full risk for that population cost. So then they went to the clinician and said, you know, we need to take care of these people. You know, we need to make sure they don't go to the emergency room whenever they don't need to. We need to make sure they have their colonoscopies done so we can save lives from colon cancer. It's a preventable disease. We can save deaths from breast cancers by doing mammograms. So fast forward to 2010, and Medicare realizes that fee-for-service Medicare patients totally unmanaged. They go anywhere they want. They can see any doctor they want. And there's no pushback on what pharmaceuticals are used. You know, that's why Medicare patients, why we spend so much money in Medicare.
And that's what would be called traditional Medicare.
Fee-for-service Medicare.
All right.
So 2009, the ACA was passed and gave us the Accountable Care Organization. And so the Accountable Care Organization then said for the first time that clinicians, facilities, DME providers of all kinds can voluntarily come together and form an organization for the purpose of trying to meet the triple aim: high quality, member satisfaction, and efficiency and cost of care. That's exactly the definition of an ACO.
Okay.
And we can now share data. We can try to help, especially primary care, know what the high quality things are to do. And that will now adjust their professional fee schedule through MIPS.
What's MIPS?
Okay. So historically, the physician professional fee schedule for Medicare patients has been adjusted pretty random. There was no method to do it. And then in the 90s, when HMOs came along, they decided our professional fee schedule became attached to the relationship between the rising cost of care versus the rising cost of the standard of living, consumer price index. And so that started in the 1990s. For the first 2 or 3 years, it was about even. But after that, every year, cost of healthcare rose about 9%. CPI was about 3 or 4%. And so each year would have reduced the professional fee schedule for clinicians by 3 to 4%. Finally, in 2015, Medicare recognized that, this doesn't make any sense because it's not controlling the cost of care. And the politicians recognized that it was not effective. And so they kept kicking the can down the road and did not assess the physicians the full amount of what that would have impacted. And so when MACRA was finally passed, Medicare Access and CHIPS Reenactment Act in 2015, if they would have applied that cost adjustment, our fee schedules would have dropped 26%.
Right. At that point, if they would have followed what they had intended to do and reduce the reimbursement to physicians based on the consumer price index, it would have really kind of gutted the physician income.
What would have happened really was physicians would have quit taking Medicare patients. Already in the country, only, there were about 30 to 40% of primary care that didn't take Medicare anyway. And so if you would have applied this, you would have lost access by Medicare patients to most all clinicians, right?
Right.
And so MACRA came along and implemented MIPS, the merit-based incentive payment system. And so what MIPS is that those quality measures that the ACO are using, the performance that you have as a clinician will then adjust your professional fee schedule. And so it was to be a zero-sum game. The clinicians that succeeded would get an increase. The physicians that did poor quality or chose not to participate would receive a negative fee schedule adjustment. And so the first year or two, that's really kind of what happened. And then pretty much 97, 98% got on board, and they at least, achieved at least a neutral fee schedule adjustment. And so Medicare had to start pitching in extra dough because there was nobody contributing the negative.
Oh.
Medicare chips in about $500 million a year to pay if you're in the exceptional performance level of at least 85 points. And so that's how the professional fee schedule is adjusted now. So the ACO benefits clinicians through a shared savings value-based contract and then MIPS adjustment. If you don't do that as an individual clinician, you don't get any shared savings, but your fee schedule is adjusted by your MIPS performance. So each year you have to produce, there are 4 domains in MIPS that you've got to report to CMS in order to get your fee schedule adjusted positively.
And this is only related to ACOs?
This is related to Medicare fee-for-service.
Okay.
The ACO organization allows us to aggregate eligible Medicare clinicians to be able to help them to be successful in this so they don't have to do this reporting individually. We do all that reporting for them. We help understand the regulations and interpret it to them, just help them know what they need to perform to, and then we report it all for them, except for the promoting interoperability out of their EHR. And they have to report that if they're on a different EHR than what we have. But for an individual, if you're going to participate in Medicare, then you have to report those 4 domains yourself. It's about cost, it's about quality, promoting interoperability, and improvement activities.
So let me see if I can grab onto some of this.
Okay.
This is the traditional Medicare fee for service. And for those physicians who are seeing Medicare patients, they have to keep track in these 4 domains. They have to keep track of their metrics. And then the government will reimburse them based on these metrics. And they're all kind of compared to each other or grouped together. Maybe help me with that part.
Sure. So
you can tell how totally lame I am in this department, but I am learning it, Roger. You're getting me there.
well, I'm glad to have this opportunity, Patty, because I think that this is an understanding that many clinicians who have worked only in big organizations are insulated from.
Sure.
There's a large part of the population, especially in the central parts of America's healthcare, rural America and not the coasts and where there's more sophisticated care, that live this world. And so it's good that we can have a conversation to help you understand this, because it really deals specifically with what you're talking about. Clinicians still need to be deeply involved in leading our country in delivering this care, right? Okay, here's Medicare. There are two populations, Medicare Advantage that we've already talked about. So you've got an insurance company that is you're credentialing as a clinician with, and you choose whether you're going to be taking care of their patients or not. And you negotiate your fee-for-service contract with that Medicare Advantage company, okay? As Medicare beneficiaries become eligible for Medicare, they choose to take Medicare Advantage, or they choose to do just straight fee-for-service Medicare.
Now, before we move off Medicare Advantage, you mentioned how a medical group or a health system can choose to offer a Medicare Advantage plan, and they can choose to have a narrower group of physicians. In a way, you implied that would allow them to keep better tabs on the quality and be able to oversee the care and meet the metrics. And I wonder if, on the other hand, if that also can be abused and make it really a disadvantage to be part of Medicare Advantage. If you're in the wrong hands, if you're in the wrong Medicare Advantage plan, it might be a huge disadvantage. Can you address that before we shift over to traditional Medicare?
I think you've got a really great point, Patty. Medicare Advantage, let's use a group. You can contract with a Medicare Advantage payer if you're a single physician or if you're a large group. And Medicare Advantage, you've got to provide network adequacy, meaning in order to sell your product, your membership has to be able to have primary care and surgeons and specialty care and, all of these services within a certain range for your membership. They can choose to have a very narrow network. In other words, choosing only certain physicians out of that area, but they've still got to provide enough access for you to be able to sell the product. And so, that doesn't mean that they're going to always be able to choose who the best physicians are. But then once they're in the network, they can see those patients. And if you're an individual, you can contract with them, fee for service, and you can even have a value-based contract with them that gets you some quality payments if you meet their quality measures. If you're big enough, if you're a big organization, kind of like the Trinity Clinic was, and you've got a big enough primary care base, especially, then you can negotiate a value-based contract that's not only got quality, but has a shared savings component, saying, okay, Medicare Advantage company, Humana, will work with you. And if our MLR is less than 85%, then for all the dollars down to where we perform at 82%, that 3%, we're going to share 50% or 40% or whatever. We're going to share in that savings.
And what's an MLR?
You'll love this.
Uh-oh.
Medical loss ratio. That was fingernails on the chalkboard when I first started learning that terminology.
Okay. You use that term in reference to shared savings.
So the Medicare Advantage company, they're paid by Medicare for each individual member a specific amount of money. So they have a budget built on how many people they take care of, that they're responsible for the risk for, and what Medicare pays them. Of that budgeted amount, there is a number called a medical loss ratio. The components of that include all of the medical services that are rendered for that population, the surgeries, the admissions, the primary care, all of the professional services go into making that MLR, that medical loss ratio. Above the line, that 15%, that's administrative. And so that's your money for profit and to administer the plan.
Okay.
Okay.
Mm-hmm.
So if your MLR, the money that is actually spent in caring for the patients.
Oh, I see why you took exception to MLR, because it's referring to medical care and what physicians do as a medical loss. Yeah, that is charming. I get it now.
You get it?
I get it. It's our job.
It's what we do, and it's what we're supposed to be doing. Medical loss ratio.
I hear you.
Pull my hair out. So anyway, and you negotiate the number. It's typically 83 to 86%. If you're below that, then you negotiate the percentage you get to keep, and that's the shared savings.
Okay, because you'd expect that you'd set it at 86%. That's either what we would expect to be spending on providing healthcare to this population, or it's what we've historically spent. But anyway, you agree on it. And then to the extent that you can be below that, then there is presumably a savings there that you can split. The medical group or the health system have some agreement about how they split it.
Exactly. That is exactly what happens.
Okay.
You've got to have a pretty statistically large size population for that to work. They won't negotiate one of those contracts if you have less than 5,000 members.
One thing, Roger, from the patient's point of view, coming in to one of these systems, I would want to have, what I need available. If I get some weird disease or need a procedure or want a procedure that maybe is in the gray area, I wouldn't want to have to fight tooth and nail or think that I'm combating this drive that it sounds like both my physician and the payer would have to reduce costs so they've got more money to split. Maybe I don't want to be a party to that. Maybe that doesn't sound like a good deal for me. What's the good deal for the patient here?
So the good deal for the patient here is typically now Medicare Advantage has a lower premium and provides more benefits than fee-for-service Medicare. For the same premium, you'll get vision services, dental services, you'll get a silver sneakers benefit for the gym, things that are not available through fee-for-service Medicare. But the trade-off, you're learning that, is that, you've got a limited number of clinicians you can see, and there's going to be managed care. There's going to be guidelines now that are applied to whether those things that you just talked about, if they are new procedures or unusual procedures, there is either an algorithm of you've got to have tried tiered system, you've got to have tried this first before you can go to that, which is typically evidence-based, so that this is a less costly way and has a high success rate. If you've not tried methotrexate before you go to the expensive rheumatoid arthritis medications, then you need to try methotrexate first, unless there is some compelling reason. And then that takes a conversation. That's why there is a medical director of a health plan, so that you can have a peer-to-peer conversation to say, well, for this particular reason, this patient, this medicine doesn't work. So I really need to use this medication. And the medical director goes, oh, yeah, I get that. So, yeah, you can do that. So that's kind of the way that works.
That's so helpful and would require some assessment of the Medicare Advantage plan.
So I have a personal bias. I think that there are for-profit, stockholder-owned organizations that have a bit of a different approach to not-for-profit organizations.
Compared to not-for-profit?
The not-for-profits may have a more socially conscious way to approach caring for members and patients. Still got to make money, but you're not having to pay the stockholders every quarter. It makes a difference in how you approach caring for your membership.
It sure ought to, right? Since these organizations that own huge institutions and big swaths of land don't have to pay any taxes. So they sure as heck ought to be very much focused on the patients.
That not-for-profit, you're obligated to show that you're providing X percentage of your care to indigent populations, which for-profits don't have to do.
Right.
But still, they're not paying taxes because of that.
Right. And I think sometimes in the more sinister not-for-profit world, there are ways to scam that.
I agree.
What is it? The 340B expenditures and getting that money and making money off that, which is supposed to go to the indigent population, but they actually make money off it and then they count it towards their community benefit. You buy that, or am I making that up?
I think you're exactly right.
So it sounds like it definitely would pay to take a close look, maybe just call Roger with a question about the Medicare Advantage plan, the one you want to latch onto. We'll provide your cell phone number in the show notes, Roger.
Go right ahead.
Yes. So that's Medicare Advantage. Wow. That's so helpful. And you were going to contrast it, I think, with Medicare traditional.
With that, you can see any doctor you want. There's no management, in essence. Right now, of eligible Medicare beneficiaries, 42% in America are choosing Medicare Advantage. That number is increasing each year. So for the 58% that do not, you have a number of people being cared for by clinicians that are not organized, that are independent clinicians that are not organized at all. And they're just taking care of Medicare patients, right? And so they don't have any shared savings. They're not in an ACO. They are influenced by MIPS. Their fee schedule is adjusted by MIPS. And so they have the labor of doing that work every year. And the benefit of that is that their fee schedule is adjusted by that. And that's a minuscule amount. It is 1% or 2% on every patient that they see. An ACO, what we've done is we have aggregated 800 primary care clinicians. We have 60,000 plus Medicare beneficiaries that we care for. And what we're trying to do is influence the utilization in a way that we are, in essence, saving Medicare money off of a budget that we're given to care for those people.
Yes. Mm-hmm.
Medicare Advantage is being paid per individual based on how sick that patient is. Medicare is now setting our budget also based on how sick that patient is, aka HCC coding, hierarchical category codes. And so we have our budget set. And if we save 2% off of that budget, then we get to share a percentage of it depending on our contract. And so we then distribute that back to our primary care clinicians as a financial benefit for doing this value-based work. So what the patient gets out of that is 800 primary care doctors that are trying to get them in for their diabetic care, their chronic disease management, their cancer screenings. And we're providing nurses, team members to help them call those patients to get them in for those services.
So in an organization like yours, you're overseeing this program that is trying to make sure that these 800 primary care physicians have the support and the metrics that they need. You provide the support and the tools, resources, information, the metrics in report form so that they know how they're doing.
That's right. They want to see patients. They don't keep up with all these regulations. There's not enough time. And so I get up every day and my team and I, that's what we take care of for them. And we try to create user-friendly processes to help them be successful in this. And we have virtual visits on a regular basis. Now we have a team also of nurses that are trying to help you. If you'll allow us to do this, our nurses can place these orders for you. They can call the patient. They can get them in. They can get these services done. And so you don't have to do that work because you've decided, because we've got a quality committee, we've got a way that you have input.
And when you said we have virtual visits, you're talking about you have virtual visits with them to support them and help explain some of the processes.
That's right.
Okay.
Here's what I need you to do so that I can help you be successful. I think the whole point of this, Patty, that needs to be communicated, and if I haven't done it well, tell me, but the whole point being, it is recognized in our system that we need to move from volume to value. We need to. There are obviously people that are resistant because they're making lots of money off of it, and people just don't like to change. You know, when is our Medicare trust fund going to become insolvent? 2026. And so it is important to the taxpayer, to the people of our country, that we are on this journey. clinicians don't learn this in medical school. They don't learn this in residency. There need to be clinicians that are involved in doing this every single day to help our partners and then to try and influence the system to where we need to go. I'm not politically motivated, but the AAFP has made proposals to Congress about how to change the payment system to incentivize primary care. And that is the way to help move this from volume to value. That JAMA article I referred to that was written last month, I'm going to send you that. It highlights the fact that the more primary care that any population receives, the lower the cost of care through the lower utilization of low value services. The patient-centered medical home, all of the primary care, family medicine literature is replete with the fact that primary care needs to be empowered more. Right now, we spend 5 to 6% of our healthcare dollar in primary care. It needs to go to 10 to 12%. If we did that, we would cut the cost of healthcare dramatically.
5 to 6% of our healthcare dollar is spent in primary care. That is just an amazing statistic. What the heck are we doing, Roger? Where's this money being spent?
Procedures, hospitalizations, all kinds of DME, pharmaceuticals. The fastest rising portion of the cost of care is specialty pharmaceuticals. It's skyrocketing.
And any ideas that you might have about how we could make this shift to properly use our resources?
So I think that CMMI, the Center for Medicare and Medicaid Innovation, is really focused on this. And so they are proposing different payment models. That's where the ACOs came from. And they are proposing capitated models for primary care. And so I think eventually that is really where we are able to do the best work. Are you familiar with Iora Health?
Yes.
God bless them. Those are venture capitalists. They started their organization as a tech organization. They built their own EHR and all of that, but they focused it around team-based care. And all they take care of is full risk Medicare.
What does that mean?
That means that they're capitated with Medicare Advantage.
Okay, so Medicare Advantage plan.
Yep, that's all they see. They want two-sided risk. They want as much of the dollar as they can get without being a health plan. So that MLR they're going to work on, or they're going to actually negotiate a capitated payment for taking care of a population of Medicare Advantage patients. They'll take the risk. I will take care of 5,000 of your patients, and you're going to pay me this amount of money. If I make money, I keep it. If I lose money, I lose money. They build the team around a primary care doctor.
That's a nice shift.
I totally agree. To me, that is the model for American healthcare. If you combine direct primary care in a team-based role that way, that's what is going to make the difference. But my objection to, and it wasn't objecting to, the presentation that the doctor made. What was her name?
Dr. Jan McCabe-Lentz.
McCabe-Lentz. And so it was awesome for her. And I love that. But what are we going to do with all those folks that just can't afford to pay a monthly payment for their healthcare provider to be available in addition to their insurance?
A lot of them didn't have insurance, or they had, catastrophic insurance.
They had catastrophic insurance because the primary care doctor is not going to be able to pay for that, right?
Right.
If you put those concepts together, I think that really works. If we're paid appropriately to provide that team-based care led by a primary care doctor, a family medicine doctor, an internal medicine doctor, I think that's the way you get to the most efficient cost with the highest quality and member satisfaction. You got people taking people to the grocery store to teach them how to shop and teach them how to cook.
Wow. I mean, I've heard of even systems, right, that build a local grocery store in order to really serve the population and improve health. And you're talking about something similar, that being part of a practice. So you would envision something like that, a capitated primary care physician-led team taking care of a population of patients and then innovating whatever they can imagine, whatever might actually serve the patients to improve their health.
Of optimized care, what percentage of what we do contributes to that optimized care?
Methinks it's probably kind of small.
10%. 90% of it is other things like social determinants of health, some genetics, but primarily social determinants of health. So it's recognizing that, so much of what impacts the health of people is not what we write as a prescription, but it's listening to what is happening to them and addressing them. Transportation, food security, so many social determinants that really impact healthcare. And so to me, that's the model that we need to have. Our country's resistant to it because a majority of the money is being spent in hospitals. The American Hospital Association, the American Pharmaceutical Association, and to some degree, even the AMA is driving the narrative. Although the AMA is beginning to get it, that primary care is really, really important.
A big part of the point you're making too is, I can tell you embrace the advantages of what some of these direct primary care physicians have experienced, which is glory be, they get to actually spend time with patients and talk to them and listen to them. And you're not going to find out about the fact that Doritos are the only thing available within a mile of where they live. You've got to have time to talk with them and understand what's going on with and develop a relationship with them and connect with them.
Your most recent conversation with Jack, that was one of the emphases that he made. That trust that we receive, we need to value that.
Yes, we need to value it and we need to safeguard it. And I wonder if you would speak to that. You know that it's been a big part of the podcast, has been talking about some of the moral injury and some of the predicaments that physicians are in, where they're caught between their obligations to patients and their ethical responsibilities versus what their employer is insisting on. And what have you seen in that realm?
It's pervasive. Whether doctors are doing it to themselves or whether it is the organization refusing to change a policy, I'm an advocate to ensure evidence-based care is the most important way that we approach patients. Doctors are the ones that need to continue to say that, because to your point, business people are focused on the bottom line.
Right. I think it isn't so much a matter of demonizing people who want to put profits first.
Right.
It's a matter of us having the courage to stand up and say, not in my organization, not under my medical license.
I'm Episcopal, and so I always use the example of the three-legged stool. It's our theology.
Say more, Roger.
If it gets out of balance, fall off. I'm all about profit, but not at the quality cost or evidence-based cost or the member satisfaction. Gets out of balance, and you've got a problem. You and I are trusted with information about an individual that nobody else is entitled to.
Mm-hmm.
And we need to honor that. It's like no other relationship that a person has.
Yes, I agree. And of course, the soapbox that I will always be on is the profession has to be led at every level by physicians. It has to be led by people that share the same values. If we want to protect that trust that patients put in us, we have to find a way to be leading healthcare organizations in making these decisions. You mentioned pharmacy and the costs of pharmaceuticals, and especially the specialty pharmaceuticals. I'll refer people to the my pharmacy benefit manager episode, where I did a very deep dive with the former AMA president, Barbara McEnany. In your role, you must somehow be connected to the need for physicians to make these prior authorization calls. And can you talk about that? How crazy making is that for physicians, and what are your thoughts on it?
Yeah, that's been a learning curve for me as I've gotten involved in the health plan. So I really had to learn about that. I'd never done peer-to-peers from the perspective of the health plan. I'd always done it from the perspective of the clinician. The things that I do realize, things even I learned before this, pharmaceutical companies drive a lot of cost that is unreasonable through their promotion. Something I've objected to all along is TV advertising of prescription drugs. Whenever that started, I had people coming in and asking for things. So there's pressure to not use the generic that works most effectively. So as a medical director, you have algorithms that you look at, but then it takes clinical judgment, like I was saying, of you calling that doctor and saying, I want to know what your reason is for not going through this step therapy so that I can work with you to get this patient the right medication for their disease process. Sometimes they just have not gone through the step therapy. So they just capitulate and go through the step therapy, which is the best thing for the patient. On the other hand, they've had to go through the step therapy and then they have to call me to get the next level. And I don't like that. That shouldn't happen. And the state of Texas just passed a law, and it's going to remove those authorizations if 90+% of the time. If you're not denying these, then they don't have to submit an authorization.
I don't understand. So if you're not denying these, what do you mean?
Authorizations are intended to direct clinicians away from a service that's not provided very often, and you're denying it most of the time because they're not using the standard care. But if everybody's using the standard care and they're only calling you every once in a while, and then you're not denying that, then there should be no reason for the authorization in the first place.
So the Texas law, then it sounds like from what you're saying, is going to say that if you've got a certain track record that shows physicians are doing the right thing, then it's not allowed for prior authorization demands to be put in place. You can't call them, you can't hound them if usually they do the right thing.
That is correct. Yes, it is great. The TMA supported this.
TMA is Texas Medical Association.
Yes, we're just waiting for the regulations. And so that's a good thing. There are some egregious things that are happening. When I was in the Trinity Clinic, there was a compounding pharmacy that was just faxing to clinicians saying, use this compounded medication and patients won't have to take these oral medications for pain. The actual contents of the pharmaceutical that was being compounded, the components of it cost $5 and they're charging $1,500 a month to compound it and send it. Those kind of egregious things, that's what you have to try to avoid. And so that's the bad part of it. So those are the kind of things that I've been learning, not be an obstacle to care and yet try to help do the right thing for the patients too.
Yeah. I can't let you escape without asking you about the EHR, electronic health record. We have thoroughly demonized it a number of times on this podcast. I'll take full responsibility for that. One of the biggest complaints is how user unfriendly and really what a monster impact in a very negative way it's had on the physician career. I'd love to hear your perspective on the good, bad, and the ugly of the EHR.
So again, I'm old and I draw on history. Quick story. When I first set up my practice in 1981 in Kilgore, Texas, I inherited practices from two older in their 70s, retiring family medicine doctors. They'd been in Kilgore for, 45 years practicing medicine. I inherited two trays of 5x7 file cards, and that was their medical records. And each patient had one or two stapled together, delivered a baby, $50, sore throat, penicillin IM, $7.
Wow.
There was nothing of value in that medical record. I installed my alphabetical medical record process, and still it was a challenge to care for people and to know all of their history. We would draw blood in my office. Twice a day, they would send a courier, pick up my blood, and it would take 5 to 7 days to get a report. I have to tape into the record so that you'd have to leaf through to see each of the results, to compare. I have a problem list that was handwritten, and I'd put on a sore throat, and I'd scratch it out. How many pages of that would you have after 20, 25 years of caring for somebody?
Right.
I had two partners, one on each side. When I was off, they'd come to my office and get the record on my patient that they were seeing. And then if I got called on that patient, where's that record? I wouldn't have any information on them, right? I lived this for 20 years.
I have to say, I think about 25% of my patients in the 90s, we couldn't find the paper chart. In a big system, the paper chart can be all over hell's half acre. It can be anywhere across the metropolitan area.
Yes. And so in 2012, we went big bang. All of our organization went on to Epic. We had to reassess how we did quality. We had to write quality into it. And so I was involved in helping to define the clinical decision support, the quality measures, how we were going to display it to our clinicians, how we were going to then build our team to help them succeed in that. And so as we build Epic and as we build our EHR, whatever EHR you use, it does need to be intuitive. It needs to provide what you want to see about that patient without a bunch of clicks. And it's clinicians that need to be involved in writing that. Technical people are excellent. They're required, but these machines shouldn't own us. We should own them, and they should be the servants of us.
It's like the contrast between technology that works, which we're all terribly familiar with, like an iPhone, versus this thing that makes you want to throw the computer out the window.
To your point, there are small EHRs that independent clinicians, all that they can afford, and what they purchase is a business management system. And oh, by the way, here's a documentation piece that goes with it.
That serves the coding and billing, right?
Exactly.
It's the tail wagging the dog.
Exactly. What I like about Epic is very configurable so that as clinicians, we can influence how the documentation is created, and you can create shortcuts and ways that documentation is created more efficiently. And then to your one podcast that was talking about having scribes, either using dragon speech or scribes, I think that should be a standard. Getting back to my whole point about only 5 to 6% being spent on primary care, tell me what happens when a surgeon is about to perform a surgery. He has a team. They're provided for that clinician for that procedure. They want to make sure that doctor has everything they need to do that in an efficient, effective way.
Yeah. There's no debating who's really got the connection with the patient and who's in charge.
Yes.
It's clear that physician has to be in charge. We've got that level of education, and it's on us. It's our accountability.
But in primary care, what are we provided as support? We may have an MA.
Right.
When a surgeon steps into that operating room, they've got a pretty darn good knowledge of exactly what they're going to do. When you stood outside the hallway of door number 3, what was behind that door? Why don't we have a team just like that surgeon does?
Right. Absolutely.
That team needs to include somebody to help you with documentation so you can pay attention to that patient. I would tell the patient, look, I got to document some stuff here. And then I would say, now it's your time. I would almost be knee to knee to them if they were sitting in the chair. Tell me what's going on. So many times clinicians can't feel empowered to do that because of time pressures or other things. That's what the interference is. And I agree with that. But I think that these machines are so important to us to help population health. They collect the data and they organize it in a way that help us to improve the health of an entire population down to the individual. And they're so necessary and so important. Rather than us demonizing it, let's embrace it and make it work for us. Let's make it like an extra nurse. The way I used to present it to my partners is, you know what? These quality measures and these things are not intended to take your place. They're not intended to interfere with you going in to see that patient. They're intended to get all the work done so that you can focus on what that patient is there for to help them. And that's why we have standing orders and clinical decision support built in, a team of nurses doing the quality outreach, and a team of nurses helping us with transitions of care, and a team of nurses helping us with high-risk patients so that you can focus on what you're trained to do, and that is take a history, do a physical exam, decide based on the labs, to assimilate all of that. And the greatest things that physicians do is they make decisions based on not having every piece of evidence because it never exists. That tacit knowledge is that you're talking about that only we have through those 20,000 hours of training and those many more hours of seeing patients one after the other, of having that trust that nobody else has so we can understand them.
The physician career is such a precious resource, and we are really squandering the time of extraordinarily highly trained physicians and stealing from them, in a way, stealing a fantastic opportunity and a noble career. Boy, I am on the soapbox. Do you think it's possible to have a system like Epic and have it working swimmingly?
I think we're closer to that. I think that leveraging the scribes is a way to help that be done.
There's another podcast that I did with Dr. Topher Obitz, the ED president. And my gosh, they just insisted on everything working for the physician and creating a fantastic career. Voila, they've got excellent outcomes. And nobody really understands the phenomenal amount of money saved if you don't have turnover, much less if you've got a lot of discretionary effort. If people are just loving their job and doing their best, it starts to rain money. Our business people don't really seem to understand that. So what are your thoughts about physician leadership and the need for physician leadership?
So I think your statistics on physician leadership are really enlightening and insightful, and I have appreciated those. I really, truly believe, to your point, that's why I promote your podcast so much. I think we need to step up and be the leaders. I think we're part of the problem, though. We abdicated this a long time ago. We wanted to see patients. That's what I was trained to do. I would have laughed at you if you would have told me that I was going to have a role like I have right now. I never would have envisioned myself doing this kind of work. I also recognize I've been 40 years practicing medicine, and I see a lot of what I think are the problems that are created for patients. And I want to help my partners come along and do it. And if I don't, as a physician, do that, it's not going to happen because, to your point, they're not bad-meaning people. I'm not demonizing them, but they don't know what we go through. They've never been in a room with a patient and heard their needs and tried to figure out how to meet them and not be able to because of resource constraints.
Right. It's not their jam.
It's exactly right.
It's what we chose to go into. And that's really why I named the podcast Licensed to Lead. Leadership is part of it.
I agree.
So, Dr. Fowler, we covered a ton.
And
I have learned so much.
Well, thank you. I hope some of this is useful to share with your listeners.
It's been fantastic. Thank you. Thanks again to Dr. Roger Fowler. He's been the most consistent giver of feedback since I started the podcast. Appreciative comments as well as in-depth critiques. So let it be known, I will listen and learn from you and might even lasso you into being on the podcast if you'll simply talk back to me. So shoot me an email or click on that hot pink voicemail tab at licensed2leadpodcast.com. Okay, fact check and correction time. Not only did I get the name of Dr. Marty Macary's book wrong, it's The Price We Pay, not whatever I said, but I also mispronounced his name. It is Macary, not Macary. And for clarity, in this episode, Roger and I refer to Dr. Jen McCabe-Lentz. She was my guest on the podcast for episode number 17. That was all about direct primary care. It triggered quite a big response from Roger at the time that it was published, and in this episode, he explains why. And one final point, please sign up for our newsletter. It will let you know every time a new episode comes out, but it's also packed with scintillating information. In this newsletter, we have a glossary of sorts that will guide you through the alphabet soup of government programs and much, much more. And there's always the BFO, which is my big fat opinion column. Well, that should do it for now. Once again, as always, thank you for all of your care and caring.
Thanks for listening to the Licensed to Lead podcast. Be sure to visit licensed2leadpodcast.com to join the conversation, access the show notes, and sign up for our newsletter. Leave us a message with your provocative question or your thoughtful comments. You might inspire a future episode of the Licensed to Lead podcast. Thanks so much, everyone.